There's no authority in the Constitution for such an act. But there is something in the Constitution that we can use, which is that states cannot interfere with the right to privately contract. So in my mind, tort reform, the proper way to do it is for the federal government to mandate that states pay attention to contract law, meaning that if you have a patient come in on an elective basis, that it's legal for the physician to have the patient sign a contract stating that they will not sue for pain and suffering. That would be constitutional. Unfortunately, the tort lawyers prevent you from doing that in the states. So, right to contract to eliminate pain and suffering would be the proper constitutional approach. Second, why is primary care insufficient in this country? You're not paid. I mean, it's kind of interesting. As I travel the country, the most, for lack of a better term, the most socialist leaning physicians tend to be the primary care doctors, and the most anti-socialist physician tends to be the specialist. And it's just backwards. It's the government that set the price caps, known as Medicare, that keep primary physicians from being paid more. If you had a market where no physician took third-party payment, okay, no insurance, no government, you just say, I'm a physician, I'm going to just charge my patients. When you do that, office visits are only $40 to $50, they're not much more than an oil change. It's not unaffordable to get medical care in a cash-based market for virtually anyone. And the other thing is, who will patients value? Because right now, remember, I laugh when I hear physicians say, well, the government doesn't value me. The insurance company doesn't value me. Well, of course not. What planet are you living on? The only person that can value their physician is the patient. So in a world where physicians do not get reimbursement from third parties, only one thing can happen. The most valued physicians are going to see their pay go up, and that's primary care. So you stand to greatly decrease that disparity in payments in a cash-based world. Cuba, I can't ask. Cuba, why is the life expectancy longer in Cuba? And the second thing is, life expectancy and infant mortality are the two most abused statistics in the world. Number one, I'll tell you what, let's rephrase it. From age 30, which country has the longest life expectancy in the world? The United States. From birth, which is the longest? Japan. There's a difference. That difference is we have a cultural abyss in our young people, especially in inner cities with gangs and drug and all sorts of things like that. We have a lot of deaths in that teenage, early adolescent, early 20 age group that wipes out the population and gives us a skewed life expectancy. The better question is, if you get prostate cancer, breast cancer, heart disease, or any of these things, where are you most likely to survive? The answer, the United States. We have the best medical care in the world. Life expectancy is completely meaningless. Of course the Cubans are healthier because they got a much better diet and they exercise. It has nothing to do with medical care. The second thing is infant mortality. Any baby of any given birth weight, longest survival rate, United States. Most countries don't count as babies the babies we count. France, as an example, anything before 26 weeks, they don't care, it's a stillbirth. So it doesn't count their statistics. The Japanese have the lowest infant mortality rate in the world, as long as we're going to use a flawed statistic. Their insurance plans don't cover pregnancy care. That's all, people do that all on their own. So once again, these statistics are completely meaningless. Whenever you see them, they're worthless. And I think that's good for now.
So there's lies, analyze, and statistics. I think Vince wants to respond, and Arvin, actually, you have some insight on the AMA. So Vince first, then Arvin.
Sure, I just wanted to give a little follow-up on what's going on with the tort reform. We talked about a law being passed here in Illinois in 2005 that did have caps on non-economic damages up to $250,000. So it is correct that the Democratic administration caps on non-economic damages was not in play. But I think that the medical societies have been not vociferously, because there was a trade-off between the SGR, which was a financial mechanism that was not good for them, and the caps. There are 4 different areas that are actually being worked on. One is health courts, another is early disclosure and compensation programs, the third is administrative determination compensation model, qualifications, and liability protection used to evidence-based medical guidelines. So while we're not going to see that type of medical malpractice reform that is the number one issue for physicians, which is the caps on non-economic damages, I think there is room for a lot of negotiation on this, and we will get some types, I think, of tort reform on this. It just won't be the number one we were looking for.
I just wanted to add two thoughts to the malpractice discussion. One is, does everybody understand what non-economic damage means? It does not mean compensation for lost work, wages, does not mean medical expenses, does not mean the usual things that cost money. But it means pain, suffering, and the most important concept is loss of consortium. I was away from my home, couldn't sleep with my partner, and therefore I need compensation. And those are the reasons for everybody not agreeing to non-economic award limits. When we talk about caps, we are only talking about non-economic awards for the most part. The second point that I don't want it to be lost, in many states, or in most states, or all states, the biggest lobbies, if you will, on behalf of medical professionals is the State Medical Society, and most states. So whichever state you practice in, you need to start looking at who's on the medical society board and who's on the insurance company board. Many of the insurance companies are on the side, run by the medical society. They were started by the medical society and may have become autonomous. And there is a lot of cross-fertilization between those two groups so that there is a conflict. And I think you need to ask that question as you involve more and you provide your own insurance. Extremely important to recognize that conflict. Thank you.
Any other questions? Yes? Oh, we have two. Okay, first back in the corner, I can't see. Ayla, you want to introduce yourself briefly? Okay, that was Dr. Puri, who's one of our basic science faculty, and I think this time I have the two questions right. So the first one is, she cited the example of Mayo Clinic, which the doctors are salaried and the cost of care is relatively low, and could that model be applied? And the second one is under the reform, would people who have cancer requiring expensive care, would their opportunity to be cared for be jeopardized? So first, is there anyone who wants to tackle the first one? Arvin, you want to try?
As far as your question on Mayo's Clinic model and the employed or salaried physicians, let me say that there are two sides to the story. One side is that physicians, of course, do not have that incentive to order more tests than they can do the same day at Mayo's Clinic. The Mayo's Clinic operation is more of an efficiency model as opposed to the salaried physicians versus practice physicians. And the reason I say that is understand that several years in practice, like 35 years for me, I took call every single day I was in town. And it was not unusual